Evening, dear colleagues and friends. We'd like to welcome all of you to MEOM Meeting. Today we'll have the fourth episode of Cataract series, and it will be about all about subluxated lens and cataract. And also we are having an eminent speaker with us today, international speakers, and we are going to have Dr. Safwan Bayati, Dr. Wasim Al-Tarudi, Dr. Hassan Khalid, Dr. Yahya Salah, and we have also Dr. Sergio Canabrava. Also, he will be cannot join us live. He just make it a recording, especially for the MEOM today. Before we start, I have a certain point I want just to clarify. First of all, regarding the certificate of quick that was done on February, we already start sending, and we have sent more than 1,000 almost certificate, but still there is a lot, because the attendees was online, more than 3,000 attendees. So those they are already get their certificates, they're well and good. The other ones, they will get it soon. We hope to finish within the next week. We apologize for the delay because it's not in our hand. It was by the CBD. The CBD of the ministry, they delay us that much because of the many requests they are asking just to approve the certificate. And to issue the certificate, they have a special company. This one, it will be not the same for the second point that I'm going to announce, our MEOM conference that will be on 23rd, 25th of September this year. Most probably it will be virtual. We are trying to see if we can do it hybrid, but until now we are not sure, but most probably it will be virtual. And we'll get the certificate immediately after the conference finish, as we are going to get it not from the ministry, we are going to get it from another CBDs in the Emirates. Also, for this so many people, they are attending our MEOM. They can get the certificate before you leave, please. There will be a link available in the chat. Just go to the chat before you close the meeting, before you end this meeting. At the end of the meeting, before we close, we will put the link in the chat, so you can go there and just fill it and put your name and the email, correct email. Then you will receive your certificate immediately in your email. This is the point I want to announce before we start our meeting. And now I want to go with my dear friend Dr. Wasim, and he is going to give a talk about Zedra and the work and the effect of the Zedra in the management of the dry eye. Dr. Wasim is a specialist ophthalmologist in IBSAR Center in Dubai. Dr. Wasim, the mic with you, please. Thank you.
Thank you so much, Dr. Mohammed. Dear panelists, dear colleagues, good evening. And I'm Dr. Wasim Trudi, and I'm going to share with you my experience with Zydra for treating chronic inflammation in dry eye. I have no financial disclosures. And actually, this does not apply if you are dealing with a dry eye. Dry eye, you need to be an internal medicine doctor as well, and a life coach, and maybe a nutritional specialist above being an ophthalmologist. So what's dry eye? As per the definition, dry eye, it's a multifactorial disease of the ocular surface characterized by loss of homeostasis of tear film combined by ocular symptoms where the tear film instability, hyperosmolarity, inflammation, eye damage, eye surface damage, neurosensory abnormalities playing an etiological role. It has three types, which is the evaporative one, the most dominant one, mixed, and aqueous deficiency. It's very important to evaluate the risk factors of dry eye in diagnosis and in the treatment of the disease itself. Like aging and like topical systemic medications, other factors, prolonged use of computer hours, contact lens wearer, low humidity like in our region, and some other ocular surgeries. Sex and hormonal changes plays an important role, and other systemic diseases like connective tissue disease, autoimmune diseases, acne, and rosacea plays an important role as well. So who is at risk of dry eye? Actually, from the ocular point of view, we have the cataract candidate or cataract patients, contact lens with LASIK candidate, glaucoma patients. But tell me, who is not in risk? All of us, we are doing long hours of screens and mobile phones. So all of us at risk of dry eye. In diagnosing dry eye, we need to consider the symptoms of the patient. We need to assist them properly. We need to standardize the approach and have the questionnaire done in a way that we can evaluate our patients for the future as well. Ocular surface condition by doing the stain, and the tear film stability and Meibomian gland function should be evaluated as well. Sometimes there is a lack of correlation between the signs and symptoms of dry eye, and it seems that our region is a leader worldwide in the prevalence of the dry eye disease. This is the management algorithm which is offered by Tifus Deuce 2 for the treatment of dry eye, and in my opinion, step 1, it doesn't apply only for dry eye patients, but it should apply as well for anyone who is in risk to develop dry eye. But those who had the disease already, step 1 applies for them, but their actual treatment, I believe, starts in step 2, and here where LFA1 antagonist, lefitigrast, Zydra fall into the treatment. So in order to address the disease, there is a multi-factors that we need to modify, adjust, address to restore the homeostasis of the tear film and to break the vicious cycle of inflammation. It's very important to break the cycle and not to mask the cycle and not to mask the patient's symptoms and keep the inflammation taking place and the disease will progress. We know lots of anti-inflammatory medications that we are using, topical corticosteroids, some type of antibiotics, and the cyclosporin. And recently, we are lucky to be the 3rd country in the world after US and Canada to be introduced to Zydra. What is Zydra? Zydra is a first-in-class prescribed therapy thought to target both active and inactive T cells. Zydra, it's designed to target the interaction between LF1 on the T cells and ICAM1. This interaction is the key mediator of inflammation, actually, which may contribute to the chronic and sometimes to the progressive nature of the dry eye disease and its signs and symptoms. And here I want to share with you a short video about introduction about Zydra.
Specifically designed to target a source of inflammation in dry eye disease, it is thought that Zydra targets both inactive and active T cells, thereby helping to disrupt the continuing cycle of inflammation. Zydra blocks LFA1 on inactive T cells from binding to overexpressed ICAM1 on the ocular surface and may prevent formation of a specialized cell junction between specific immune cells, which may inhibit T cell activation. Zydra is thought to inhibit migration of activated T cells to the ocular surface and may reduce cytokine release. Zydra is a first-in-class prescription therapy thought to target both active and inactive T cells in order to interrupt the chronic cycle of inflammation.
So that was the video, and where and how it all starts. It starts by the questionnaire. We need to standardize our approach to the patient in a way that we get some numbers that will trigger the diagnosis of the disease and would be able to help us for the future to follow up the progress of the treatment. Then we need to look for the signs, and there is a 2-point of care test, in my opinion, which is very important to be used in evaluating the dry eye disease, which is the tear film osmolarity. Should be above 308 milliosmol per liter, or a difference between both eyes of 8 milliosmol per liter. Inflammatory, there is no numbers to measure it. It will give you the test positive or not. And definitely we need to evaluate the tear breakup time, ocular surface stain with either invasive or non-invasive manner if available. Then a careful look at the eye examination, especially the lid condition and the eye surface. I follow here the look, lift, pull, push advised by the ASCRS technique. And then when you collect your data and analyze it. Now I'll be sharing with you how I'm building my experience with Zydra for the past couple of months. It's up to 5 months actually. This is case number 1. It's a 52 years old female. She has a history of both eyes, cataract surgery with multifocal lens. She has a negative systemic medications and systemic history. She is using eye lubricant with lid hygiene. She's complaining of blurry burning sensation, foreign body sensation, and fluctuation of vision. She's not happy after the cataract surgery, especially with multifocal IOL, and she's claiming that the surgery has triggered her symptoms. What are the risk factors? Number 1 is age. Number 2, she's a female with hormonal changes at this age, the cataract surgery. She is living in an environment, although it's very humid outside, but we are not exposed to humidity. It's a very low humidity in the AC conditions. And she is a user of this Arabic kahal, which is a mix of heavy metals and heavy user of makeup. The dry eye questionnaire is giving a score of 14, which is positive for the screening. And now we need to look for the evidence. Tear film osmolarity, it was 310 positive for the screening of the right in the right eye, and it was 316 in the left eye. Slit lamp examination, it shows like slight remnant of makeup on the lid margin, minimal eye congestion, clear cornea, and you can see here the multifocal IOL. A closer look to the lid margin is showing that we have a significant lid margin telangiectasia with lid margin scale, and that kind of blepharitis that may be due to demodex capping of the Meibomian gland orifices. The fellow eye is showing the same findings as you can see here, and now you can evaluate the tear film breakup time. It's really less than 10 seconds. Already starts to break down in this area, and this is the corneal stain as showing in the picture. Doing the lipiscan to check on the Meibomian gland structure, it's clear that we have a structural damage, a structural changes, glands drop out and atrophy with some congestion in the Meibomian glands. The last piece of the puzzle is to detect the inflammation, and this is the MMP9 test. The inflammatory is showing really a significant inflammation over the eye surface, although the eye looks like white and quiet and not congested. So a dry eye diagnosis is established. Maybe there is a component of rosacea that was not sure 100% of the examination. My treatment strategy starts with the basic package, which is basically kind of step 1 approach and the TFOS use recommendation, education about the patient condition, oral fatty acid supplements 1 gram per day, change the humidity, especially at night during the sleep in the bedroom, and try to reduce the makeup use if possible. And then we need to treat the ocular surface inflammation. I start my treatment with topical preservative-free artificial tears eye drops. Topical Zydra takes place here twice per day to control the inflammation. And bear in mind that this is a long-term treatment because it's a long-standing inflammation. Short-term of steroid, maybe I added for the first 2 weeks in this case as well. Then I do for the patient, I treat the multi-factors of her dry eye and multi-etiologies, like she has blepharitis, so I did a session of blepharal microexfoliation to treat her blepharitis, followed by home lid hygiene with eyelid wipes, and especially it should contain, for now, the tea tree oil to address demodex. IPL treatment, which I'm suspecting to have demodex. IPL treatment, she has a heavy lid margin telangiectasia, and the IPL helps to reduce this and reduce the ocular surface inflammation. I did 3 sessions over 6 weeks. At the same time, I did a LipiFlow session to improve the condition of the Meibomian gland dysfunction. In patients where I suspect rosacea or facial rosacea is there, I delay usually the warm compresses for a couple of weeks because it will increase the patient discomfort at the beginning. 3 months after treatment, this is the eyelid, how it looks, and this is the eye surface with stain, how it looks. It looks pretty good. What I want to highlight here is the MMP9 test after and MMP9 test before the treatment. It shows how significant the improvement of the inflammation, which I believe Zydra has contributed in here. That concludes the first case. Case number 2 for a 45-year-old female. She's a teacher and she's complaining of redness in the morning, watery eyes, burning sensation several years for now. She has a negative medical history. She is using over-the-counter eye lubricant and using some eye drops to control the eye redness in the morning. The OSDI questionnaire, it was positive. And the risk factors, again, she's a female, extended screen hours. She was involved in the distance learning during the pandemic, and she's living in low humidity and using an eye makeup. We can see here the tear breakup time. I hope it's clear. It's showing that it's within normal. Nothing is happening less than 10 seconds. So there was tear breakup time is normal. This is the slit lamp examination. There is a mild congestion in the eye, lid margin. It looks somehow within normal limits. And there is no signs of clear blepharitis. Again, MMP9 test is positive for inflammation, and the tear film osmolarity, it was a bit high, which confirmed the diagnosis of dry eye. The meibomian, which is obtained by LipiScan, it shows slight changes in the structure of the Meibomian gland, as it's showing here. And so we have here a patient. She is positive for the questionnaire. Some risk factors are there. Tear film osmolarity is positive for the diagnosis, and she has inflammation. And the patient, she has a floppy eyelid syndrome as well. So she has a dry eye. Again, the treatment strategy, education about her condition, changing her sleeping habits because she sleeps face down. I asked her to change her sleeping habits, topical preservative-free artificial tears 3 times per day, topical Zydra eye drops 2 times per day to control inflammation. Usually when I do the LipiFlow, I combine it with blephar-microexfoliation for each patient, and that gives a better results in my hand. This is 2 months after the treatment. The OSDI score has dropped significantly. This is after the treatment, and this is before the treatment, the inflammation, which indicates again an improvement in the ocular surface inflammation. Patient right now referred for lid surgery to correct her floppy eyelid syndrome. In case 3, it's for a 32-year-old male. He is complaining of redness, pain, and photophobia in his left eye in the morning. That comes every couple of weeks for the past 2 years. In his history, he's feeling that his eyes is dry since 5 years, and he's using artificial tears and ointment at night. He mentioned that he was treated with temporary punctal plugs that has caused worsening in his case. There is negative medical history or treatment. He's smoking. He's a heavy mobile user, and he's living in low humidity. His OSDI score was quite high. The slit lamp examination is showing mild eye congestion, especially in his left eye. Slit lamp photo of the cornea is showing the place of the recurrent erosion and maybe a basement membrane dystrophy. The fluorescein stain, it's clear in both eyes. There is a significant severe damage to his ocular surface and to the cornea, especially in his left eye. Tear breakup time is kind of that dirty tear film with lots of debris on it, but you can evaluate that the breakup time is really low. Here I would like to mention the Meibomian Gland Evaluator, which is a small machine that it has a spring that delivers pressure over the eyelid, which is equal to the pressure of the blink of the eye. I apply it over 3 places on the eyelid, the temporal and the middle and the nasal side, in a way that I can count how many functioning glands are there, and I can see the meibom which is coming out of the glands, how's the nature of the meibom, and I can evaluate the meibom as well. Again, to finish the pieces of the puzzle, there is clear structural damage. There is glands dropout and atrophy and congestion in the lip scan. We can see here, trust me, we need 10 minutes to read the MMP9 test for inflammation, but this patient, after the second minute, he has this severe red line is there. So the patient, he has a severe dry eye because there is a severe eye damage as well with Meibomian gland dysfunction, recurrent erosion, basement membrane dystrophy, and severe ocular inflammation. The treatment strategy, definitely the starting package, education and omega-3. I stopped the ointment because I don't like to use ointment if there is severe inflammation over the eye surface or punctal plugs. I started an autologous serum eye drops with topical prophylactic antibiotics, topical preservative-free artificial tears, short-term steroid for 2 weeks, and the topical Zydra eye drops twice per day to reduce the inflammation. This patient, I have seen him actually this week. I mean, I started his treatment. He came to me since a couple of days, and I did for him a session of IPL treatment to try to reduce the ocular inflammation. And I delayed the blephar microexfoliation with the vector thermal pulsation for 2 weeks because I need to address the eye surface damage before I go to more invasive procedures like the blephar microexfoliation. What I want to deliver a take-home message: inflammation, sometimes it's overlooked and underestimated in dry eye treatment. So please look for it, find it, and break the cycle. Thank you for your attention.
Thank you very much, Dr. Wasim. Very nice presentation, excellent, and very nice cases you provide with different type of patients. We will leave the question if there is any of our panelists they want to ask you or question. If there is any question also for our attendees, participants, they can send or they can raise their hand so we can give them the chance to answer or to ask the question, and they will get the answer from our dear speaker.
How much is Zedra?
How much? The price?
Yeah.
The price here in UAE is around 700 dirhams.
700 dirhams?
700 dirhams, yeah.
Around $200.
$200.
$200, and he needs to use it, the patient, for how long?
Actually, he needs to use it for at least 3 to 6 months to control his condition, and especially in severe cases, yeah.
But it's a very informative lecture, very important, and it shows how much somebody should take care of this subject.
Yes, I agree with you, especially, yes.
Give time for the patient and wait for the results and see the evaluation, then prescribes the treatment.
Now, Dr. Yahya, you raise an important issue, and I need just to comment on Dr. Wasim, that in my cases, I have around now 52 cases, and all of them is being treated only with Zydra. And my trial is just to see what's the effect of the Zydra, that we can add it only without the use of any. And all of my patient was complaining, having all the positive things that Wasim mentioned it. And within 2 weeks, the first issues that they start to be asymptomatic. Really? I have one of them. She was suffering for a long time, and we were doing everything apart from the other medication. But when she starts Zydra, because Zydra break up the cycle and prevent, so it's a preventive and treating, and that's the important issue with it.
Dr. Safwan,
just 2 weeks you start to be asymptomatic, and that's important.
Just a comment. I'm doing this holistic approach for dry eye for some time right now, and before I've been using different medications and comparing to the experience of patient with Zydra. Although I'm doing this holistic approach, I really have noticed that their improvement is faster than before. Although I'm doing the same regimen for all the patients, but definitely with different medications. So yes, I agree with you. It's the mode of action, the onset of action. It's very fast. And I believe it is addressing the signs and symptoms of the dry eye.
Exactly. So that's why
thank you.
I didn't do like a trial only with Zydra. I was treating the patients. Yeah.
Thank you, Dr. Safwan, Dr. Wasim. We have many questions from participants, but Dr. Wasim, before we move to our attendees there, how do you decide to give? I mean, for us, we give in moderate, or we give in severe, or we give it in the mild. When you are deciding to give the Zedra, is it suitable? Do we need to depend on the actually the test for the inflammation or not? Because not everyone is having this one to do the test. Sometimes even the patient is not suffering and is not complaining, and when you test him, you find him like one of your cases that not much, but he is having I mean an inflammatory indicators of the inflammation. In the other way there will be a lot of severe. Sometimes they cannot tolerate, and when you test and you examine the patient, he is just having a mild dryness. So
that's correct, and that's a very good point, Dr. Mohammed, because in my opinion, once you detect the inflammation either clinically or by the test, you should treat. I'm talking in dry eye. You should treat.
We are talking about dry eye.
Yes, because we do have some flares of a controlled patient with dry eye. If he has a seasonal allergy, that's a different story. But about the dry eye and the inflammatory process of the dry eye, once I detect the dry eye either by clinical examination or by, for example, if there is an ocular surface stain, that means there is damage. This damage will not come without inflammation. So here, even you don't need to have the test. Maybe the test will give you an indicator where you have started and after treatment, where you will be, and compare like what I have showed. But I have showed some cases here that really, if you look at the eye at the beginning, the eye looks white. There is no clear indication of congestion, which is one sign of the inflammation, but not the only one for sure. So in my opinion, once you detect the inflammation, start the anti-inflammatory treatment. And since it's a chronic disease and a chronic process, I don't think that corticosteroid, for example, will be suitable for such a long duration of treatment. Yes, I can use it at the beginning to give a faster effect to the patient, but definitely I need to use some immunomodulator treatment to control the inflammation. So once I treat it.
Okay, just we need also a because we have many questions, if you can give a very fast answers. Yes. Dr. Wasim or Dr. Safwan or Dr. Usama also, he's our Dr. Yahya, Dr. Khalid, anyone have also to give his opinion here. I mean, sometimes do you think the indication of using Zedra, it is moderate to severe, or you can use it in any type, even mild? This is yes or no, mild or all?
Now, in my opinion, is that when the patient is symptomatic, when the patient comes to me and the breakup time is less than 10, and the patient is symptomatic, here I can start now. And not any
he is what? He is symptomatic or asymptomatic? Symptomatic, okay.
Symptomatic means that the patient complaining, and when you are testing the breakup time, you can see that it's
we need a very short, if you don't mind. Mild, you will give or not?
Mild symptomatic, I will give mild, because mild as a definition, it's a controversy. Symptomatic.
Yeah, I know, but in general, we have an idea about the mild, what we mean. So, Wasim, you will give in the mild.
Yes, and I think the only one who is not mild is the one who is the pre.
Just without yes or no, because we want to ask fast. Sorry, but we need to.
I agree. Yes.
Okay, Dr. Usama, if you are with us.
Hi everyone.
Yes, hello. You are most welcome, Usama. Habib.
Thank you very much. Basically, it depends if it's very mild. It depends what mild also. So still, you start artificial tear alone initially and see how it responds. But many of our patients, they come to me, they're already using artificial tear, no improvement. That's so straight away I know that. So that's different to what mean mild really in general practice.
Okay. So I mean, it can be given in a mild. This is what I want to say.
Yes, it can give me in a mild, yes, and especially if the patient already start artificial tear, not better.
Okay, next question. Do we need to give a steroid? Because I know in case of restasis, we are the action, it will start, maybe you can see the action after 2 to 3 weeks. That's why yes, but we are giving a steroid in the beginning, so until the action of the medication start. In Zedra, I don't know. For me, as far as I don't know, but you can correct me. You don't need to give. Well, so Dr. Safwan, you need or not?
Exactly. You don't need.
You don't need. Okay, Usama?
Depends, really. I usually give it for a week or two when start Zydra, just to help people compliance and just to reduce the inflammation quicker. And not work
Wasim,
quicker.
I think you already give, that mean you are giving.
Just I give it for a week or two, but not everyone, okay? If it's very mild, I may use alone, but I usually give steroid.
Okay, we are having here another questions, just not that questions I was asking mine for me. For there is another participant here, I have Prashant Bahatia. He is asking, how do you decide when to stop Zedra? Wasim.
Yes, I start when to stop it after I, first of all, there is the ocular surface is healed if there is stain, and the patient is asymptomatic. Tear breakup time is within normal, and by that time I'll start to stop and monitor the patient, and I'll keep him on artificial tears as well.
You know, Dr. Wasim, if you allow me, so many times, dry eye, it's a continuous, there is no complete healing. So do you think maybe you are decreasing the symptoms, not just cutting all the symptoms or remove all the symptoms? Dr. Safwan?
If the patient understands that this symptoms coming from his behavior and he didn't change his behavior 100%, it will return back. So if he understands that the behavior that he is doing, just like Wasim said, sleeping on the face, staring on the computer without blinking, and now I'm using a new categories of time, 20 minutes and then 1 minute of blinking. So they are putting a sticker on the screen, and they are putting sticker on the phone, blink every 20. So once they are seeing the sticker, the yellow or red sticker, they need to blink. So, and prevent sleeping on one eye or two or both. So these are factors. When they are prevented, 100% they will cure. But when they're not,
Safwan, I think if you allow me, but also Safwan, to be honest, there is so many factors playing in the dry eye.
Exactly.
And according to the lifestyle, it is very, very difficult to control.
The majority of them.
That's why I think maybe, yes, we can treat the patient for a while, and maybe he can continue on another lubricating drops. Then after that, you can go back if the severity come back. If this is my conclusion. Yes, Victoria, yeah, please.
I just want to add, practical thing, particularly if you don't have Zydra or restasis, whatever, like Dr. Wasim was saying, it's the holistic approach. And I think one of the most important things is the lid hygiene.
Yes.
If you teach the patients how to clean the lids, swab it, whatever whatever is available, I think this is important. A drug alone will not be the solution, because as you said, it's a chronic thing, and they will have to live with it, and you are improving their lifestyle, but they have to learn how to do, among other things. But the lid hygiene, I think, is very important.
Victoria,
don't you think hygiene only related to just those they are having meibomian or blepharitis? But it's not everyone having dry eyes having this one. It can be one of them, but it will not solve everything. Because the dry eye is a multifactorial.
Yes.
Okay, Usama, I think you're open to comment. Yes.
Basically, the duration, prepare yourself to use it more than 3 months, really. Logistically, you need much longer than that. In America, some people they are already 5 years they're using Zydra, okay? So especially moderate severe, they may carry for long time.
Probably insurance.
We have insurance cover here. So the good thing is insurance covered here.
Insurance covers it.
Another questions. There is one question before we move, because we are having only another 2 minutes only, then we have to start our next session. What about, this is one question from Muhammad Jassim. He is saying, what about restasis rule, if it is better or the same effect of Zedra? I mean, there is a difference between both of them? If someone can give a hint about this.
I think there is no like head-to-head studies between Restasis and Zydra, but from my own experience, I believe that the onset of action of Zydra is the one which is giving the priority in treatment at this stage, and the mode of action where it blocks the inflammation at the beginning of the pathway, so it's kind of preventive as well. It helps a lot. So I believe in my experience that this is the difference for now, and definitely in the future we need head-to-head trials.
Thank you. Just also in very just yes or no, we don't want more. What are the contraindication? Is there any contraindication for Zedra, for example, Dr. Safwan?
No, I don't believe that there is a contraindication. The only issue is that the
Okay.
tests sometimes
Yes or
are
no?
getting bad tests. Only one complication that
allergy only. If it's an allergy to the drug, that's it. Nothing else.
I'm not facing this problem.
Yeah.
Okay. So I mean, this one of the thing is bad test, but I think that the solution that after you put the drops, you can just ask the patient to put their finger on the nasal side and to prevent the. Okay. So what? This is a question for Dr. Wasim. Why did you stop ointment in the last case?
Because the patient has severe inflammation. If you will plug the punctum or put ointment, you will entrap the inflammation over the eye surface, especially overnight. He was using it as a lubricant overnight for the recurrent erosions, and I replace it with the autologous serum, which will make his condition better in a faster mood. So once I control the inflammation, I'm happy to use the ointment again.
Okay, so this question was from Dr. Muhammad Al-Mursi. We are having also Burhan Ad-Din Urabi. Please, can you give the name of medication containing tea tree oil? Is having any idea?
Actually, there is lid wipes, which is not available in the market so far in the UAE. I asked them to search on Amazon eyelid wipes with tea tree oil. You'll find 3 or 4 medications. So just go Amazon eyelid wipes with tea tree oil.
Okay. Then the last question. For a patient 50 years, which with keratoconus, I think, and almost she weird hard contact lenses, mentioned there is an effect of hormonic changes, and there is a moderate to severe dryness. Is it benefit to use Zedra, and when it applied before or after insertion of hard contact lens? So patient 50-year-old with keratoconus
in general,
hard contact lenses.
Yes, the management of dry eye, there is inflammation, needs Zedra, you need to start it half an hour before and after. You need to keep a gap half an hour between the contact lens and the Zydra.
Okay. I think we are having only another 2 questions. If you allow me just 1 minute before we move. Can you stop share, Dr. Wasim, so we can have Dr. Safwan to start sharing? Meanwhile,
yes,
we can get this question.
I will.
Does the inflammation and symptom returns after? I think we answered this question, right?
Yes.
It can return if the patient, Dr. Safwan mentioned, he is not following the instructions, and he is not and exposed to all factors that leads to inflammation. Is that correct, Dr. Safwan?
Yes, sorry, I'm just repeat
okay,
it.
Wasim, it's okay?
Actually, I wasn't follow you. I was
okay. Both of you not concentrating.
I'm sorry.
Yeah, because I'm concentrated. I need to share. That's not the issues.
Okay. So I will ask Usama if you are with me, Usama.
Yes.
Usama, does the inflammation and symptoms return?
Depends in the depends how is the disease stays that time. So if the disease is still active, it will return.
Okay. The last one, could the male patient have been sensitive to this one? I think for Dr. Wasim.
Yes.
He's asking about, I think, the last case about the patient who was 32-year-old. He is mentioning could the male patient have been sensitive to lanolin in the ointment?
Actually, he used the ointment after the onset of his disease. So, I don't think so, no.
Okay. Thank you very much. I think we can now move, and we are going to have now my dear friend, Dr. Safwan, and he will start our session. This is the episode 4 of Cataract series, and today it will be about the dealing with subluxated lens or cataract and how to prevent and manage. And we are going to concentrate about the new methods that now available, and those they are not yet available and they are going to be soon available in our area. So Dr. Safwan, he will start the loss of capsule support in cataract surgery. This is the one. Dr. Safwan, the mic with you. Yes.
Good evening, everybody, and good morning, good afternoon, according to your place, your time. Great, thanks, Dr. Muhammad, to give us this opportunity to present this important and interested for all of us subject, which is the loss of capsular support in cataract surgery, and all of us excited to have, because we have these problems, and that's why we need to know how we can solve and what's the newest things to solve it. Now, let us start with my financial disclosure. I don't have, unfortunately, any financial disclosure here. Let us start with what we were doing in 90s. And I need just to remind ourselves that we were using AC lens with all its complication, a wide incision, suturing, and guiding glides, and so on. And then we tried to get rid of these to get rid of the loss of endothelial cells count, to do a scleral fixation. Once started with the 90 polyproline and with the hard lens. Still we were doing an incision, and that incision need to suture, and those lens was prepared, if you can see of the screen, and it has a holes in their haptics, and it was going through an incision in with the two suture coming through, and the flap in the sclera, peritomy and flap in the sclera. You can imagine that it was a revolution because it was in the bag, but still we are doing an incision, flap, and the suture. After a while of time, it start to degrade, and we face a dislocation again, or subluxation of the lens. Then glued started. The glued IOL with those heroes, Amar Agarwal with his son and Dr. Suzanne. Now they start what we called a flap on and tunnel, and they put the haptics in the tunnel, and then they close it with the glue, and that glue should be there, and then they close the conjunctiva with. Now, still they are using that technique, and and some of us, they used it here in Middle East and Egypt, but we found that there is a lot of issues, and we need to prepare a lot of equipment to deal with the flap and the holding the lens. That you can see that there is a micro tying, gauge 23, and there is a lot of learning curve in that technique. Let us go to Jortex. When started, it was started with the glued, or they were parallel to each other. The Jortex suture is a polytetrafluoroethylene, and it's used first in the eye by Professor Richard Hoffman. Now he create a lot of methods, the cowhitch technique to hold the haptics, or he was using a pocket technique to hold barrett the suture. What I will show in my technique, which is published by other doctors, it's the use of micro tying, and that micro tying gauge 23 through a sclerotomy without a flap, and holding the sutures inside. But in that technique, we need a 4 eyelets lens, and that movie will show clearly what was in doing scleral fixation using Jortex. Now in this technique, we need either AC maintainer or the infusion cannula. Here I had some lens matter inside, so I did my work for a vitrectomy, and then I start. Now 2 millimeter from the limbus, 3 millimeter apart from both, I finish the removal of the lens matter, and then I start enlarging the sclerotomy, preparing for introducing of the gauge 23 micro tying, and that's the gauge 23 micro tying. I'm just trying to introduce it, then implanting the lens, which is the physiol. I don't have any financial disclosure with it. 4 eyelets, turning the physiol to the 3 and 9, the eyelid to the 3 and 9. Intraocularly, I'm guiding the suture from out to in by holding the suture tip through the micro tying gauge 23, through the eyelets, and holding it out. This technique, I'm using it now with the 5-0 nylon also, and we will discuss it later. So we will show the one side, that's the one eyelid now through, the other side through the other eyelets, and holding it and taking it out. Then the loop will start it, and that will happen to the other side. The same issues to the other side. You can see that this is the first eyelet, and then to the second eyelet. It's very easy. And then 2 loop, holding the lens inside and tying the vortex, make a loop and the knot embedded, and then we finish the surgery. Here, this is the sign of the suture under the conjunctiva post-op. If it's buried in a good way, it will not leave any trace. But sometimes we have pigmentary changes, and sometimes we have inflammation. And the main issues that we face it after is the hypotony and the suture reaction. So it was a concern. We were overcome it in certain way. Now, later on, there was a revolution in 2015 and 14 and 15 and 16 that through a Yamani technique. Mr. Yamani showed a double flanged technique where he was using a lens 3-piece, and he succeeded to take the tip of each flange through a transconjunctival prick through the gauge 27. He was using it gauge 27 in the beginning, and he succeeded to take this haptics out. The things that he used, gauge 27 or 26 needle, and sensor and lens with 3 haptics, and cautery. And we can see we start to difference in the requirement, simplifying this requirement, and it's transconjunctival, sutureless. He was not using any suture. So that's the technique. I'm using eye simulator. And this is very important for the one that he needs to start with. And it's present online. Anyone he can ask for it. And he can start with it like what I'm doing in this movie. And in this movie, I'm just doing some modification. So 2 millim with 2 millim on the other side. And it should be exactly toward the other side in a way that the lens will not be tilt. 2 millim and then 2 millim on the counter side of the right side. So the left is counter side to the right side. And then the needle, the one that I will start with, it should be bent 9 millimeter. See, this is the 9 millimeter bent. And the bevel should be toward my side, the bevel face. The other needle, I will bend it fully here, because that will be the last one. Because the first one, it should be movable, and when it moves, it should be short. And that's what I need to show. And then the lens, here, I just need to show everyone how the haptics tip can pass easily through. Here, the bevel toward my side, and it can pass easily through the bevel and it can hold in, and then I can hold it and take it outside, externalize it. Now, that's what I did in the other one. Now, injector, the lens will be in, and then we'll go in. Now, the only modification here is that I will take the leading haptics away, supporting the lens, and I will start with the trailer haptics. That's in reverse to Yamani. Yamani, he's doing fixating the leading haptics first, and then fixating the trailer haptics. And that's a modification by Brian Kim, and I think that it supports the lens much better and easier. Here, I'm just holding the lens in, and we can see that easy to handle the trailer haptics. The needle should be in the groove, that 2 millimeter, and then bent. The beveled will be toward my side, holding the trailer haptics, pushing it inside, so simulator will be important because this is the first case that I'm doing. I did it by simulator. That needle will be free. So I'm not holding now this needle. Now I'm using the second needle, which is the 11. The face, you can see it. Now how it will be turned toward the other side to facilitate the entering of the haptics, the other haptics. And now I'm out. Holding by gauge 23, cauterizing the tip. And this cauterization, the flange should be simple as it can, not slipped, and it cannot exposed. So the other one, it's going on, and the same issues. And here we finished, return back this haptics back to the groove, and the lens is in the center. Now we will go to the real movie, and this is the real movie. Now you can see that also was drop particles of the lens. You can see transconjunctival 2 millimeter to the right side, the nasal side, and temporal side to counter 2 millimeter. And then 9 millimeter for the first, and 11 millimeter for the second needle. Preparing my paracentesis, should be 2 sides, and at 6 o'clock, this is the modification, then entering the site, the main incision for the introducing of the lens, for delivering the lens. Here I'm just testing all the 9 millimeter in, I start with. Introducing the sensor lens. Why sensor? Because the haptics of it carry material like the polypropylene, and it will not break when it will be bent. That's why I'm using it. The haptic is outside. This is the leading haptics. So it will hold the lens. And now we will start with the trailer haptics. The bubbled, holding it. Tip bubbled in. And the tip, the haptics is inside the needle. I will leave. Then I will deal now with the leading haptics, then the second needle, which is the 11 millimeter bend. And you can see here I'm holding the haptics near to the end, bubble toward the other side. It will go directly, easily to in, and then going out, holding the haptics, cautery the tip. As I said, the tip, it should be cauterized. The flange the size should be not big one, not small one. Now holding the second, cauterizing it, and here we finished. Return back to the tunnel, returning back, and I finished here, and the lens in the center, and you can see everything is clear. Now, here we finished the surgery. What's happened is that later on, Canabrava presented his published paper for double-flanged and four-flanged technique. That's why I'm putting this picture, because Canabrava now, he is working on different issues that Yamani at least started, but on the same concept, which is the flange technique. Yamani, he created the double flange technique in the form of cauterizing the haptics of the lens. But Canabrava, no, he started to use the 5-0 polypropylene and holding all types of the lens by modifying it and creating the flange into the sclera and holding that lens. Brian Kim, he did a modification to the Yamani, and that's what I show it. The future coming with the CTS prepared 5-0 nylon, Sioni with one side 5-0 nylon, and Sioni with double side 5-0 nylon. And now I think that Dr. Hassan and Dr. Sergio will present their presentation to show what we four-flanged, double-flanged, and two-flanged, and these are the issues that now we are using. And I show you in the Jortex that we use Jortex in Acryos and in Physio. Now I'm using 5-0 nylon instead of the Jortex, transconjunctival, and here I'm not using any stitch and no peritomy. Now, here in these pictures, we can see that there is a few issues related to the lens on the right side up. The lens is being cut from the three-piece and the haptics of its cut, and they introduce the 5-0 nylon in both sides, and they did the creative flange, and then they hold the lens. And here, lower down, you can see that it is a test to see the durability and the tensile strength of the flange, and it was done successfully, and the other haptics being cut, but the flange is not being cut. And here on the left down shows that one-piece lens, how it's they are preparing it for a flanged suture 5-0 in a way that we can use this technique for any lens. That will be shown by Dr. Sergio and Dr. Hassan. And here, this picture shows clearly that even the iris, artificial iris, we can do it by the flange technique. Great, thanks for all, and hopefully that I didn't cross the time.
Thank you, Dr. Safwan. Thanks a lot for this very nice and interesting talk, and for the showing all the steps slowly, so that everyone can learn and start doing his own surgical intervention by following the step you are showing. I think we can proceed for the next talk, then we can have a discussion at the end of this meeting. The second one, it will be the second talk, it will be by Dr. Sergio Canabrava, and he's a speech consultant ophthalmologist from Brazil. And as Dr. Safwan introduced him, he is one of the new introducer of the new technique for solving the or treating the subluxated lens or for fixing the secondary IOL. He's going to talk about using double flank, and this one he will show in the movie that he will present. Can you, Wayne, share the screen? As Dr. Sergio, he is not able to attend unfortunately live, but he registered this or record this one especially for MEOM. And also he is going to the first one, it will be using 5-0 Brolin suture, and then he will using a ready-made 5 Brolin fix to CTS or and CTR.
Hello, thank you for the invitation to be the first time the Midwest Ophthalmology meeting. Dr. Safan, it's a great honor. I'm not here today because tomorrow is the World Webinar on Cataract Refractive Surgery. Me and Dr. Ashwin Agarwal are the organizers. And today you are so busy, then you record it before. Let's talk about the Canabrava's double flange technique. Here my disclosure about my talk, and I like to give you a brief story about the technique. I have the idea of the double flanged Canabrava when I see the Yamane flange in 2016. Then I back to Brazil, and I work in that time in 2016 with subluxated cataract. But in Brazil, it's difficult to get a Gore-Tex suture. I used in that time only 10-0 polypropylene, but you know the 10-0 polypropylene is photodegradation. Then the first double flanged in end of 16, I did it a simple polypropylene haptic that you can see here. The first surgery that changed the game, that's open a lot of surgery for techniques for main surgery around the world. Here, the first flanged. Then I insert its polypropylene in a simple CTS, and I remove the other part of this, and I insert it inside the 26 gauge insulin needle, and then it was the first double flange in the world in the ophthalmology. And then you can see here I will do the second flange, and then I insert it inside the tunnel and the IOL, and then okay. Perfect. Then I published in 2017 the ASCIS Film Festival and received the prize for this new technique. But I have some problems that you can see in this surgery that I using in a patient with a large white diameter. Then observe how was difficult and what's impossible. Then, after this surgery, that I had the idea, why not to enlarge the flange and use a simple 5-0 or 6-0 polypropylene. Till this time, nobody in the ophthalmology started to discuss about it. The polypropylene was forgotten. And then, one of my first tests about breaking test, sclera simulation here, to think if the flange will be stable in the sclera. And then the second test, you can see the break test with a single piece PMA IOL that you can observe that the haptic is break, but the flange stay stable. Then after this, I saw I can go to test it. And 2018, I published in the ASCIS for the first time, like a paper, and with a patient with Marfan. Then you can see the first adjustable suture with double flange polypropylene, the Canabrava technique in the ophthalmology. So between 2016 and 29, only me was talking about this, but for me it's an honor because since 2019, many surgeons use the Canabrava technique to publish new techniques. For example, some surgeons that I sit here, but every day I receive new videos using the Canabrava technique. Here, for example, Dr. Kashikian from Los Angeles, he was the first that used the double flange, the Canabrava technique for fixate iris, artificial iris. Observe here, observe in this video, he flanges is big, but it's normal in the beginnings. All surgeons have afraid to do a small flange. Then here my research, I work with the Canabrava technique in three ways, with CTS, with no foldable IOL, and with 4 eyelets IOL. With CTS and no foldable IOL, I suggest 5-0 polypropylene, 26 gauge needle, and with a foldable IOL with 4 eyelets, I suggest 29 gauge ultrafine or test fine TSK plus 60 IOL, 60 polypropylene. Here one case that received a golden apple in San Diego in 2019 is a microspherophakia with a patient with 7.8 millimeter diameter. Here you can see I use in my patients Phantom second. All my patients I use catalysis with a catalysis. And the young patients I prefer to use Ice Rook because his capsules is okay. But with old patients it's better to use Mako hooks or MST hooks because can break the capsule. Here I'm inserting a CTR. I prefer to insert the CTR first. Observe, this CTR is a 10-8 millimeter CTR, 10 outside, 8 millimeter inside the bag. You can't use a 12-10 millimeters in patient with microspherophakia because it don't fit in the bag. Then you can see some problem for some surgeon. Here, a fake emulsification, and after to finish the fake emulsification, I remove the cortex, and then after remove the cortex, I remove one of the iris rook, and I create the tunnel with a 26 gauge needle and rotate it to the anterior chamber between the iris and the complex CTR bag. Observe, and then I will insert the 50 polypropylene inside the lumen of the needle, and then I remove it. Then I remove it, and then I do the first flush in the CTS. I test it outside of the eye and insert it in the bag on one side. And then I repeat the movement in the other side. And then, after remove it, again, I do the first flush in the first CTS and test it outside of the eye and insert it inside the eye. You can see two Canabravas technique in each side with CTS, and then the CTS in each side, and then I complete do the second flange for the first time. Observe, cut it 2 millimeters from the base, 2 millimeters from the limbus. Observe, the flange don't need to be so large because you need to insert this flange inside the scleral tunnel to avoid endophthalmitis, to avoid conjunctival erosion, to avoid any complication. Observe, now insert the IOL in the bag, and at the end, you can see how the flange is inside the scleral tunnel. Here in this slide, you can see a brief synopsis of the material that you need. 50 polypropylene, CTR. As you could see, I like to insert the CTR in the bag to give more stabilization. A coulter, thermal cautery, 26 gauge needle, and a CTS. I prefer an angle CTS than a flat because a flat you can have a tilt it. Okay, let's see the next one. It's a brief synopsis of with illustrations of the Canabrava Plus CTS with patient with Marfan, microspherophakia. Here the iWords journal in ASCRS 2019 when I received the golden apple for the Canabrava technique, the double flange with CTS. Then continue the story. Then later of 2018, I have the idea, why not to use a Canabrava technique, a double flanged with no photo by oil. Then I create the fourth flange technique. You can see simple single piece PMA IOL that's using Malbran and Liu's technique, and with Canabrava technique on one side and Canabrava technique on another side. Then, because this I give the name of 4-flange technique. The next one, you can see a synopsis of the technique. And here, one of my first videos, here no foldable IOL, I'm using a 5.0, and you can observe that I use trocker but here before the first flange in the eyelet of the IOL, repeat the movement in the another side that you can see, and now the second flange in the second eyelet, and observe. It's important to insert in the sulcus and observe now the pronation movement to avoid tilts, because the haptic need to be in the sulcus, because there's a 30 millimeters overall. If you put the haptic outside, you can see. Then you can see the third flange, don't need to be large, and 2 millimeters and 2 millimeters from the base, and again the fourth flange, and observe. You can see insert it inside the tunnel. Observe. You can see flange during the final. Here the UBM, that you can see the IOL. The second imagine here the UBM, you can see in the number 1 the polypropylene, the shadow of the polypropylene, the sclera. The test, because after I publish this many surgery, it's possible to perform the Canabrava technique with foldable IOL. I did a lot of tests, as you can see here, with vertical, horizontal, and a punch, but sometimes it's stable, sometimes not stable. Then I know many surgeons using a technique to piercing the IOL, but I was the first one to publish it, but it's not so stable. In my results, not so stable to perform the IOL. Then I start with the 4 eyelets with you can use acrylic, it's acrylic hydrophilic, sorry, and a micropurphysiol that hydrophobic. It's I suggest this one. Artist and another IOL for OFTA. Here use show a technique with a 4 eyelets. You can see the Canabrava ring. Because this patient has a small pupil, the Canabrava ring is from edge out to edge from each band. Observe the movement that I back with the needle to create a tunnel, and I repeat the movement in the another side. Observe my hands that I back, because you need to create a tunnel. You can't go directly in the sclera. You need to create a tunnel to insert the flange inside the tunnel to avoid. And how here you can see how you insert the polypropylene in the 4 eyelets, and you back with the third first, and after back with the third, you insert the IOL inside the eye. I suggest to start the technique with a simple micro forceps or a burato forceps. Observe it. And then with the IOL inside the eye, you back. Observe how the Canabrava ring stays stable. With the IOL inside the eye, you back with the 4th point in the sclera. Observe it. The 4th point in the sclera. Now I can adjust. And now, inserting the 6.0 inside the lumen of the needle, and observe how the IOL stays stable, including with a small part. Observe, I have time to go and pull it, and now you can adjust the IOL. Observe. So slowly, don't need to have so be quickly, and now cut it. Don't need to cut now in this 4 eyelet, because you can adjust it, and observe a small flange, and you can go slowly adjust the IOL. It's the great advantage of this technique with all techniques. I know sometimes it's is low, the time of the technique, but observe how you have this time to adjust the IOL so, how can I see, you don't need to be anxious because the IOL is there. You have 4 points in the sclera. And observe, I cut the bottom points before, and only at the end I will cut the upper points because I want to adjust it before. Now I cut the third point, and then observe the flange inside the sclera, and don't need to be a large flange if you do a good scleral tunnel. Observe that you insert this, and now removing the Canabrava ring. It's a ring by PMMA. It's one ring with 0.4 millimeter thickener. The another rings have 0.8, 0.9. And observe how the IOL stays stable. And observe, after remove the ring from the eye, you can't see any flange in the sclera. Observe. Don't have flange in the sclera. The outside of the sclera, of course, inside of the tunnel of the sclera. You need to put it inside. Observe. It is the final result that you need to find. For flange by injector, after you have the four flange with a 4 eyelets, I suggest to use it with a Alcon Cat B that you can insert. Observe. And now it's important because you need to back with the cartridge, with the injector, to avoid to cut the eyelets, the closed loop of the IOL. Then you perform the technique as you can do in the second part. How about it? After about 5 years, you complete about August or September, when I did my first double flange that I show in this video. I have these numbers, and of course you have problems. I have one patient, for example, that I published it. A big flange is common in the beginning. Then, if you did a big flange back to operating room, reduce it. This patient, after 1 month of surgery, I have this inflammation. I treat it with moxifloxacin for 7 days, but corticoid. And after these 7 days, I back to the operating room and I cut it and I insert the small new flange inside the scleral tunnel, and then this patient is okay. I had one patient with large flange outside too. That's JCRO accepted it last week and to be published. New research in ACRS 2020 virtual meeting. I published this new IOL that I'm in research, but research is delayed because the pandemic time. The thing sometimes the public hospital in Brazil the place that I do my research is stopped. You perform normally that use the Canabrava technique, the double flange, and one to each side. And this new IOL, I call it shoelace concept. Observe, remove the two sides, and then you pass the polypropylene like a shoelace, and then you do more stability. Observe, and you do more stability, and then observe. It's work like a shoelace. You can perform more stability. Then using a simple forceps to insert the IOL inside the eye, but it's not available yet for patients. It's staying in research. This IOL was doing by Morsher. Sergio, what's more stable, this IOL with 2 points, or the 4 eyelets with 4 points. I need to finish the research, but till now, the 4 points is so stable. So stable. Then cut it 2 millimeters from the base, and then you finish it. I like to invite is tomorrow, because I'm not here in presential. I'm working here, but it's a pleasure to invite everybody to be in the World Webinar, May 29,
When
June
you can
5.
stop share now, please. Yes.
And
thank you. Thank you very much. I think for Sergio for sharing his experience with us and give us this opportunity to see the new, let's say, technology that's going to be the solutions, maybe the futures. Yeah, can you stop share, please? Stop share. Okay. We have now to, we can get a few questions before we move to Dr. Hassan, or do you think we can go and then we can have at the end? Dr. Safwan, what do you think, Dr. Hassan? Yahya? You are mute, Dr. Safwan.
We can proceed, Dr. Muhammad, in a way that we will get it at the end.
Okay. So Dr. Hassan, if you can just share your screen and start the last talk, and then we will have at the end the discussions. Dr. Hassan also, he is a well-known cataract and also glaucoma surgeon, consultant ophthalmologist. He is the chief of cataract and glaucoma unit in Maghrabi Eye Center in Mecca. And he is going to talk, he will give also his experience by using the 4-flank techniques and Jortex future for CTS and CTR. Dr. Hassan, please.
Thank you, Dr. Muhammad. Firstly, I would like to thank Dr. Muhammad and Dr. Safwan for their kind invitation to speak about the new and latest technology in the subluxated cataract management. Actually, I don't have any financial interest in my presentation. As mentioned before by Dr. Safwan and Dr. Sergio about the type of fixating of both the IOL and the capsular tissue rings into the scleral wall, there are 2 ways to fixation these devices into the scleral wall: by suturing these devices or by doing a flanges fixation. Actually, by suturing into the scleral wall, there are 2 ways: by using the 10-0 or 9-0 Prolin sutures. But the problem in these sutures are the longevity, as it's found by many published papers. It's found after 5 to 10 years, about 27 to 30% of these sutures have been broken or degraded. Regarding to the Gore-Tex, it's an excellent one, but it's also the longevity is more than the 10-0 or 9-0 Prolin, and its visibility while doing the surgery, it's very good. But as I see in the previous presentation for Dr. Safwan, the entrance by 23 gauge needle is more risk for more hypotony on those patients. For suturing into the scleral wall, using these sutures, it is time consuming. You need to do conjunctival berectomy and do cautery for the blood vessels. Then you need to create a scleral flap or scleral pocket, or doing a flap or doing a scleral groove. The second way is, as mentioned by Dr. Canabrava, it's the fixation of these devices, the capsular tissue rings or the IOLs into the scleral wall, using the 5-0 or 6-0 Prolin, which has more longevity than the 10-0 Prolin. The instruments that I used in my presentation was 27 gauge insulin syringe for the capsular tissue ring, or 31 gauge needle for the puncturing of the IOL, and 30 gauge insulin syringe to retrieve the 6-0 Prolin through the scleral wall. Through the scleral wall. Here is the first video for this case of phacoemulsification while I'm doing the phacoemulsification for this case. The cataract was dense, and I have more than 3 and less than 6 clock hours zonal dialysis. In this case, I suture the modified capsular tissue ring Sione ring using 10O proline to the sclera. Here is after doing the conjunctival hypertrophy, I do a sclera groove. Then I thread the 10O proline through the eyelet of the Sione using a 27 gauge needle through the groove of the sclera, then retrieve the first arm of the 10O proline. Then about 1 or 1.5 millimeter away from the first entrance of the needle, I retrieve the second arm of the 10O proline. Then you can see inserting of the Sione capsular tissue ring inside the capsular bag. And at this point, it's very important to make the eyelet of the Sione ring opposite to the maximal point of the dialysis, which is opposite to the sclera groove that I created. Then you can tie the suture, and then knot will be inside the groove. Then continue the phacoemulsification of this case and removing the cortex. You can see now while removing the cortex, in this case, the capsular bag is stable, and you can see it's stable. There is no apparent dialysis. Then ablatic, a single piece hydrophobic IOL inside the capsular bag. Then removing of the OBD from the anterior chamber and behind the IOL. It is, you can see the end of the surgery. The lens is stable inside the capsular bag. Here is the second case. This patient, I operated him 3 or 4 years ago. This patient has traumatic cataract with more than 6 clock hours zonal dialysis and mild traumatic cataract. Actually, I fixed this capsular bag into the sclera wall using also 10O proline, as the cortex is not available in our hospital. Here is the surgery. You can see that dialysis it's clear, and also there is vitreous prolapsed into the anterior chamber. I didn't do anterior vitrectomy for this case. Just I pushed the vitreous into its position. Then at the maximal point of dialysis, I create a scleral pocket. Then you can see a heavy viscoelastic pushing the vitreous back, and then doing the capsular rhexis at the sclera. You can see the degrees of the dialysis. It's more than 6 hours. Then fixing the capsule with the capsular hook or iris hook, and the cataract is soft actually, and doing hydrodissection. You can see the golden ring. Then it was easy to remove this soft cataract, and using the Simcoe after that to clean the cortex from the capsular bag. After that, you can retrieve the capsular hook in the area where is the maximum dialysis, and then go with this 10O needle in the sclera pocket and retrieve it with the cannula or using the needle. Then thread the 10O proline through the lateral eyelid of the Sione. Then the same needle back through the main incision using the 27 gauge needle away from the first entrance, about 1 or 1.5 millimeters underneath the iris, and between the iris and the anterior capsule. Then retrieve the needle as it's clear with this 27 gauge needle, then inserting the Sione ring inside the capsule. This patient also has traumatic mydriasis for the pupil. Then rotate until the eyelet, the lateral eyelet of the Sione opposite to the scleral pocket, where is the maximal dialysis, and tying this 10O proline and buried it inside the scleral pocket. I didn't do vitrectomy for this case. Here is the end of the surgery. The lens was stable and the patient was happy. I followed this patient for about 6 months, then I didn't see him. He didn't follow. Here is, sorry. Here is the secure fixation of the IOL using the another way, using the flange fixation to the scleral wall. This is a case of a patient with solo exfoliation who had operated elsewhere, and he presented to me with subluxation of both the capsular bag and the IOL. At that time, I decided to remove the complex capsule and IOL, and the pupil was very small, so I used the measuring to dilate the pupil. After removing the capsular bag and the IOL, here is the time of the scleral fixation into the sclera, doing the anterior vitrectomy, then marking the cornea, and also 2 millimeters away from the surgical limbus using the marker to mark the entrance. Here is the preparation of the IOL. This is the single piece IOL using the 31 gauge needle. Do a puncture at the middle of the haptic, then thread a 6/0 prolin through this 31 gauge needle, then using the low temperature cautery. Here is the second haptic. You can see both the flanges in the IOL, in the haptic of the IOL, then loading into the cartridge. It's very important to avoid the entangled suture to make one long, one short. For the leading haptic long, for the trailing haptic short, then using the 30 gauge needle and thread the 6/0 prolin 2 millimeters away from the surgical limbus in both sides. Before inserting the IOL, you can see here the tip of the cartridge near to the cornea, removing, then you can pull it. You can pull the both prolin, then you can implant the IOL. While implanting also the IOL, you can pull to avoid the entangled sutures. Then you can see the IOL fixed inside in the posterior chamber. Then about a 3.5 or 3 millimeter, you can do flange and buried underneath the conjunctiva. It's not inside the sclera as presented by Canabrava. And here is the second part. You can also about 3 or 3.5 millimeters. You can do the flange. Then the major ring was removed for this case, and the viscoelastic was removed from the anterior chamber. Here is, you can see this is the end of the surgery. The here is the secure fixation also with the IOL using the flange fixation into the scleral wall. Here is with some modification using both the flange technique and also Yamani technique in entrance into the anterior chamber through the scleral wall. This is a case of patient who is phakic and with anterior hyaloid face opacification. After doing anterior vitrectomy, for this case, I start with the marking of the sclera. You can see it's 2 millimeters away from the surgical limbus and 2 millimeters horizontal in opposite side for both sides. Then doing anterior vitrectomy and injecting cohesive OBD. Here is the preparation of the IOL with different modification. In this way, I puncture the optic, not the haptic, using the 31 gauge needle. Also, doing the flange in the haptic is not in the optic. Here is the first side. Here is the second side, also in the optic, just at the junction between the haptic and between the optic, just puncturing and thread the 6/0 prolin and do the second flange. Also load this IOL into the cartridge and make the suture for the leading haptic is longer than the trailing haptic, also to avoid the entangled sutures when you load the IOL inside the cartridge. As it's clear, here is the IOL inside the cartridge. Then you can ask your assistant to hold the injector near to the cornea. You can see one suture is long, one suture is short. The leading one is long and the trailing is short. Then put in the injector, ask your assistant to hold it near to the cornea. Then the same Yamani technique, go with 30 gauge needle, go and thread the 6O proline through the needle and retrieve it. As it's clear, and now you can do just secure a flange. Then the same way for the second suture, you can thread the 6O proline through this needle, then you can retrieve it in the same manner. And also you can do secure suture, secure flange. Now you can pull this suture in both sides before implanting the IOL inside the anterior chamber. Then you can implant a single piece hydrophobic IOL. Then you can pull both sides and use the Senesky to push the IOL behind the iris. And at the same time, you can pull both sides of the suture. Also, you can cut these suture 3 millimeters. Then you can do the flange. I think in common cases for me, I will do small scleral incision to bury this flange inside the sclera. As my entrance with 30 gauge needle, I don't think this flange will be buried inside the sclera. Here is the second flange. Both flanges are underneath the conjunctiva, covered by the conjunctiva. Here is the end of the surgery. Then removing the viscoelastic, and the lens was stable for this patient and his vision was improved. And here is the end of the surgery. Here is the flange for both sides, and thank you for watching.
Thank you very much, Dr. Hassan. Very nice and excellent. There is a lot of modifications, so we need to publish your modification now. It was really, it's very nice. I think now, before we move to the questions, I would like to Dr. Yahya just to brief, if you don't mind, because I know he is a well-known also cataract surgeon and he knows all about this one, just to brief all about the technique that we can use in secondary IOL, just in 2 minutes, about what we have seen. Then we can discuss what we have seen with Dr. Safwan, Dr. Sergio, and Dr. Hassan.
First, I would like really to congratulate Dr. Safwan and Dr. Hassan for excellent presentations. And they really made a great presentation. Dr. Canabrava also definitely is an excellent presentation and a lot of ideas. But we have, for the knee, if we don't have capsular support, the anterior chamber IOL, to sum up, anterior chamber IOL is not used, but still it can have its place. the scleral fixation is fading away with the sutures, particularly 9-0 and 10-0, and even the use of cortex. Then the main technique that is used now with a lot of modification I've seen are the flange technique, which makes things more easy. And of course, the Yamani technique is definitely an addition. And from there, all these modifications have been used. But only there is one thing that is missing that was not mentioned by any of the presenters, which I think it has a place, and it's very easy and very good, it has very good results, is the iris claw lens. Iris claw lens, we can use it posterior inclination. So cosmetically, it's good. It's away from the cornea. You can easily dilate the pupil and so examine the fundus normally. And if it is properly fixated, it is very stable on the long term, and it's very simple. I don't know the opinion of Dr. Safwan and Dr. Hassan about
I did it, and unfortunately, I don't know why I didn't put it as an example here, because maybe I don't like it. Artisan with the it's a clue, iris clue opposite to the back. It's one of the modalities, and I have modification in it. But the issues is that I didn't see the patients happy with it. Like, for example, 4 eyelid scleral fixation and stability, and the Yamani technique. Once I start Yamani technique, I stopped the Jortex, and I saw that the stability and the refractive outcome is much better than the upside down iris clue.
So let me ask you, Dr. Safwan, you have mentioned, you have demonstrated the technique very well. Just I wanted to stress of the importance of how to bend the needle. You showed that you bend the needle for the trailing haptic in a way, and for the
leading haptics in a way,
and the other trailing haptic in another way. So it's very important. I think it makes things much easier.
Yeah, exactly. The issues is that why I'm following the modification of Brian Kim, because I found that it's much easier and more secure. That when you are holding the leading haptics, keeping it outside in a way that it will support the lens, and dealing with the trailing haptics first, that will be the trick that 100% he published it, and he got the agreement for it. Now, the first needle that you will use, it should be short, because you will leave it. So that's why when you are bending this needle, it should be 9 millimeter. Because if you will go to my video, you will see that I left this needle with the haptics in it. And if you leave it, it should be short, because otherwise, if it will be 11, you will hit the ciliary body. So, but the second needle, it will be in your hand. So you will handle it. You will not leave it, because the second, it will handle, or it will deal with the leading haptics. And when you are pulling the leading haptic, putting it, the bubble should be away from your side. So it's easily to go through and slide into the bubble, and into the needle, and getting out. This trick is very important for the safety of the eye.
Thank you. Yeah. Dr. Hassan?
Yes, Hassan.
Yes, Dr. Yahya, yes. Regarding to the iris claw IOL, I have operated many cases, but anterior chamber, not posterior fixation, anterior fixation of the artisan IOL.
Yeah.
Yes, iris claw. I have very good result. I don't mention about it because we are talking about the fixation of this in the sclera, but I have very good result in the AC. I don't try posterior fixation. I don't know why, but actually I did about more than 30 cases in AC IOL. I have only one case with let me say that one claw is not fixed, and yes. Regarding to the presentation of Dr. Safwan, it's very nice. Thank you for this nice presentation. But I have 2 comments about the first one. Using the Gore-Tex, I don't think that using the 23 gauge needle entrance into the through the scleral wall and go with this is micro tying forceps and getting. I think this whole is two holes in one side and two holes in the other side, or two sides of penetration, I think the hypotony will be more than your expectation. I don't think, I think that the second issue is in using the Yamani technique. This is very nice modification while externalize the leading haptic out. It's good, but the second thing that I don't think it's a good while leaving the needle while drilling, while inserting or thread the trailing haptic with the needle and leave the needle and go to thread the leading haptic. While you are leaving this needle, I don't know where this needle will go. Maybe touching the retina, maybe.
That's why.
I think if you modify this one with pulling it, but keep it inside the scleral wall as you go 2 millimeter, I think it would be better. I don't know, but I think
this technique is being published in this way, and Brian Kim have a lot of cases, and I have a lot of cases with it. No one of them, because if you will see that most of the cases has lens matter, and I went in and I saw even the site of my entrance, so there was nothing. That's why the trick of it is that you need to have it's 9 millimeter. Anyway, now any modification that you will get in, the lens will be decentered or towed. Try it and see, and you will end up with. So we are keeping that needle in a way that when you will get out, you can centralize the lens, and then you can return back the haptics. And the amount of the haptics that you will cauterize is 2 millimeters.
Dr. Hassan, one question, Dr.
Important things here.
Yes, Dr. Yahya.
Dr. Hassan, did you find the difference? I liked your presentation very much. Did you find the difference between the technique of puncturing the haptic and puncturing the optic, and which one do you prefer?
Actually, the first case, was puncturing the haptic. I packed the patient inside the OR theater because I feel that the optic is slightly tilted anterior to the iris because the pupil was very small, and I used the margin ring to dilate, and there was a slight iris atrophy superiorly. So I think the second one is much better than the first one, as theoretically when you are keeping the haptic in the opposite side of the entrance of the needle through the scleral wall, it will be like this on both sides. This is the haptic and this is the suture. I think that the IOL will be more stable. The second case, the IOL was more stable than the first one.
So you like haptic, put in the haptic or the optic?
No, I think optic, yes. When you puncturing the optic
is more
I think it's
stable.
better. It's much better stable and
as
centered
we are
than
running on the time. If you allow me, we are having few questions just to clarify our meetings. First of all, let's say, what is the flange? What do you mean by the flange, Dr. Safwan?
The flange is, as you saw, that we are creating melting in the end of the suture, and that will hold something that we need to hold it through it.
I'm trying just to summarize what we have done. What is the difference between double flange and four flange?
Now,
why?
When
would you use this one?
When the concept of double flanged is created by Yamani, because double flanged means that there is two flanged in the whole eye. Anything beyond that, it's four flanged. It's not a double flanged. But here now we are talking about double. All the issues that talking about is double, but the actual things is not double. Like, for example, Hassan, he used the flanging on the optics or on the haptics of the lens, and then flanging outside. This is four flanged. It's not a double flange. Anyway, part of that, any flanged other than two flanged, this is a non-double. This is a four flanged.
It's different between the flanges in the sclera and between the if you're counting the flanges on the sclera, it's a double flange. If you're counting the flanges on the IOL and the flange on the sclera, it's a 4 flange. If you are using Sione or you are using the segment, it's only double flange if you're counting the flange in the CTR or and on the sclera. It's
is more than double. Okay.
Okay. Anyway, we have only one question, Bill. But after that, we can.
I have a comment, Mohammed. So if you will,
if you can question, then yeah, no problem.
Okay.
Just I want to all this a message to all participants. If anyone want to have the certificate, please. Now we will, if you allow me, the management even to display the link in the chat box. So you go there and just click on the link, and then you will fill your name and email and submit. Then you will get the certificate. After that, we cannot, send this link to anyone after we finish the webinars. The last question is there were this one from Muhammad Abdullah Mansour. He is asking, there were a risk when you pass the needle to rupture of the capsule, how to avoid it and manage it?
That Dr. Hassan.
We don't pass through the capsule. Actually, we pass the needle between the iris and between the anterior capsule as there is as it's passed through the maximal dialysis point. So if you remember the case with traumatic cataract, okay, we put viscoelastic, then the space between the iris and between the anterior capsule is created very well. Then the needle go between this space between the iris and between the anterior capsule. We don't puncture the capsule. Of course, it will not be stable.
Okay. Just before your comment, Doctor, this one, please. This is a message also to my dear colleagues. I would like also to say hello to my dear friends, Dr. Ba Mahfoud. He is with us here. Just please don't send your email. Go to the link, and then you can find and put the link inside the link, please. Okay. Please, if you can display the management event, please display the link in the chat box. So don't send your email. You will find the link, then you fill the link when you open it. Yes, now we have the last comment from Dr. Safwan, and if there is any comment from Dr. Yahya before we close.
The first comment is to Dr. Yahya. What's the difference between puncturing the optics or puncturing the haptics? Till now, the whole study that's showing head-to-head between 4 islets and puncturing optics and puncturing the haptics, it shows that the 4 islets is more stable. Now, what we are doing, what I'm doing personally, I'm screening the patient post-op. So I did all. I did the optics, I did the haptics puncturing, and the 4 islets. And I found that the least ocular coma is with the 4 islets. That one. Second issues for Dr. Hassan, when we are introducing the segment, first of all, when we have the subluxation and that subluxation is in, for example, 6 hours, and here before leaving the iris retractor, you can introduce that segment, holding it by the iris retractor, finish your surgery. This is what I'm doing personally. I'm just commenting, and then through that I will remove the retractor from the segment, from the Ahmed segment, CTS, and then introducing whether nylon. Now I'm using 6-0 nylon through it and in between the iris, and then through it and going through, and that more stable than doing it outside. Now the third comment, which is the very important, what we are targeting as a refractive outcome when we are doing Yamani or flunged. In my practice, I'm targeting -1 because we are not knowing the depth. And with our result, with the first result of the Yamani, it was hyperopic shift. What we discovered that the lens will be a little bit posterior because we are holding the tip of the haptics, and it will be going through that in Yamani technique. So that's why I'm targeting personally -1, and my result it's within minus 0.25. That's the comment that I was.
Thank you very much, Dr. Safwan, for
you.
this nice comment. We will have also just another message also. Please, we will have the link now already displayed on the chat box. Everyone can just go and click this link and fill the information and submit it. Then he will get the certificate. Yes, Dr. Yahya, and the last comment for Dr. Yahya and Dr. Hassan. Dr. Yahya?
Yeah.
It's excellent, and it shows how many good ideas can improve the results. And at the same time, in subluxation, there is not one single scenario, and you should be prepared with different options to manage, because it's not one technique that will fit all. And sometimes, as you have seen, you need to do more than one thing to manage the whole case.
Yeah, I think in the future we will see many modifications in these techniques, also in the IOLs type of IOLs, those IOLs with hole, which help us in doing this technique without puncturing the IOL, without do any modification for the IOLs.
The net is not good.
Okay, I think, yeah, Dr. Hassan, thank you very much.
Yeah.
Before we have to conclude one thing that, as Dr. Yahya mentioned, we are having many ways to deal with subluxated, and I think it will be affected by the situations or with the availabilities of the things. So you have to try to use what is available with you that you can manage, but also it's good to have these varieties that we can use to solve the problem and minimize future complication. At the same time, also to have a better outcome and visual outcomes. I would like to thank you all. I would like to thank you, Dr. Safwan, Dr. Hassan, Dr. Yahya, Dr. Usama, Dr. Wasim, and also a special thanks for Dr. Sergio that he sent for us the recording. Very special thanks also to our sponsoring event today by Novartis and all the team. Also, I would like to thank our management event for their support and being with us. And also, I would like to thank all the participants and to thank you all. And we hope to see you, inshallah, next Friday. We will have a very interesting sessions about the series of the cornea. And the first one, it will be about the corneal ulcer. Thank you very much all, and good night. See you.
Thank you.
Thanks,
Bye-bye.
Thanks, Dr. Yahya, Dr. Hassan.
Assalamu alaikum.